Second degree heart block. Mobitz type 1. This is also known as Wenke-Bach phenomenon. What do you see? Here, progressive prolongation of PR interval until P wave is not conducted in cycles, followed by dropped P wave is not conducted, so there will be a dropped QRS beat. The PR interval becomes normal and the cycle often repeats. So you should observe in the ECG that there will be progressive prolongation of PR interval until one P wave is dropped, and also since the P wave is dropped, QRS will also get dropped. For example, let's start from here now. This is the PR interval here is this much. Compared to this, there is increase here. Then there is more increase here. Okay. Then you see that there is a P wave, but there is no QRS. There is a drop in QRS. PR interval until P wave is not conducted in cycles. That means you are seeing a P wave, but this P wave that means the electrical activity which has started has not conducted to the AV node, to the ventricles. That's why you're not seeing the QRS complex here. So there will be progressive prolongation of the PR interval such that there will be a missed beat. That means the P will not be conducted to the ventricles and you will have a dropped beat. Following a dropped beat, that is QRS complex, and the PR interval becomes normal and the cycle often repeats. Normal here means you can see that it will be normal, then it will get prolonged, and then finally you will see a P without QRS. Then again, you will have a return of P with QRS, okay? So may cause occasional, you can see lightheadedness, that is fainting attacks in this, and also may be present in healthy children. You can also see this in healthy children, but you have to, whenever you see this, drug history is very important. Maybe calcium channel, it may be a side effect of calcium channel blocker, beta blocker, or a digoxin. As we know, the name of the drug itself is telling it's a blocker. So there will be some block here. Okay. So calcium channel blockers, beta blockers, digoxin, drugs are very important. Drug history is very important in these cases. And vagal stimulation can also be a cause for this second degree heart block and myocardial infarction. We have to always observe the progressive increase in the PR interval. Okay, so let's draw again. Let's change the color. So you can see this is the PR interval here. In the next, you see it's quite long comparatively. In the next, it's more long, followed by, I don't think here you see, this is the T. You see the P has come off here only. It's almost overlapping half of the T wave. And then there is a dropped beat here. Then again, the PR interval came to the normal. Okay, this you should learn to recognize in an ECG. Very important. So this is second degree heart block, Mobitz type 1. Let's apply to all ECGs so that we'll be learning here. Okay. Where is this is the lead usually. You see here, let's start with the P wave. This is the PR interval. Then there's a QRS complex and T compared to, again, you see this is the PR interval slightly more. This is the PR interval more here. Again, as I told you, the P wave has almost overlapped a part of a T wave and there is a dropped beat here. Usually see in this ECG, it is following a pattern. PR interval, increased PR interval, more increased PR interval, then followed by a dropped beat. So you are getting almost 1 QRS, 2 QRS, 3 QRS, 4 QRS, and then the fifth beat is dropping. Okay. 5. Here 5. So, but it depends. The main thing here, what you have to see is the progressive increase in the PR interval and followed by a dropped beat. Any comments before we proceed further? Write for me in a chat, or you can tell. You can give a comment. Okay, let's move for Mobitz type 2. So Mobitz type 2, second degree heart block, sudden dropped beat with no progression of PR prolongation and the cycle of here. What happens? The PR interval is fixed. There is progressive prolongation of PR interval. Here the PR interval is fixed, but you'll have a dropped beat in between. So let's, if we see the ECG will often every other beat P wave is conducted. That is 2:1 block. And this is more serious because it progresses to complete heart block. So prepare for pacemakers. So Mobitz type 2 and type 1, if you compare, type 2 is the more serious, and it will more often get converted into a complete heart block, and you should prepare for the pacemakers. Next is, what are the symptoms may cause palpitation, pre-syncope and syncope? Result is caused by intrinsic conduction system abnormalities. It is due to, as we know, conduction system abnormalities, rarely caused by increased parasympathetic tone, that is vagal stimulation or drugs. Okay, it can also be caused by vagal stimulation and drugs, but can be caused by cardiac surgery and also myocardial infarction. Almost the same causes like the Mobitz type 1. Like drug CCB, beta blockers, digoxin, vagal stimulation, myocardial infarction, all those things. But the only thing is, this is more serious than type 1 because it will more commonly progress to complete heart block, and you should be prepared with a pacemaker for this. Okay, let's see the ECG to understand here. As I told you here, the PR interval will be fixed followed by a drop beat. This is the difference between type 1 and type 2. So here, the PR interval is fixed, fixed, fixed. You can see there's no progressive prolongation. Three beats you can see, followed by a dropped beat here. Then 1, 2, 3, maybe here, I don't know how many here. So let's see here, PR interval. This is the PR interval. This is the PR. It's almost normal. Now, this is a P wave. There is no beat here, followed by a dropped beat here. Okay. So you should check for this. Let's go to lead 2 here. So this is a P wave, PR interval, PR interval, PR interval. This is a P wave, and there's a dropped beat here. So if this is fixed PR interval with a dropped beat after some P waves, it is Mobitz type 2, and you should be very careful with this type of heart block. Second degree heart block, as PR interval is not prolonged, so this is type 2. Now let's go to the third degree heart block. Third degree heart block, no impulse from atria reach ventricle. So ventricle is acting upon its own, atria is acting upon its own. There is no coordination between them. This is atria, this is ventricle. Okay. No impulse is reaching from ventricle, from atria to ventricle. So complete AV disassociation. There's no association between atrium and ventricle. P wave is regular and regular PP interval. PP interval they are telling, not PR interval here. Okay. QRS is regular with regular RR interval. So you are checking here PP interval and RR interval. with much slower rate than P rate. Means P rate is for the atrial rate. You will take it separately. P rate is atrial rate, R rate is ventricular rate, and there's no association between them. This is coming sometime, that is coming sometime, and the P rate will be more than the atrial ventricular rate. So P wave is regular and regular PP interval. QRS is regular with regular RR interval with much slower rate than P rate. No relationship between P and QRS complex. There's no relationship. QRS is normal from AV node and abnormal from the ventricles. If it is from the AV node, it is normal. But if it is from the ventricle, you see an abnormal Q wave. Okay. QRS complex, I mean. Ventricular rhythm maintained by a lower pacemaker. That means ventricular rhythm, it is from the ventricles. It is not coming from the atrium. Can cause fatigue, lightheadedness, and syncope caused by a disease or injury to conduction system, cardiac surgery, myocardial infarction, congenital complete heart block. Congenital complete heart block we see in babies of SLE mothers, toxic drugs, severe hypoxia, and severe acidosis. These are the causes. You should know the causes here. Very important. So I'll repeat it again. Causes is it can be from some heart disease, injury to conduction system. Usually injury to conduction system usually happens post cardiac surgery. Myocardial infarction also can cause injury to conduction system. Congenital complete heart block we see in babies of SLE mothers. Toxic drugs, severe hypoxia, and severe acidosis. So that's why anytime the patient is in acidosis or hypoxia, we are afraid things can go wrong. Let's see here what he has explained. So here, this is a P wave and this is a P wave. Okay. So the PP interval, this is the PP interval here. And where is the RR interval? RR interval he's telling. This one is the RR interval. And also this one here is the RR interval and here is the PP interval. Means there is difference. They are not going in coordination. We have to check that always. You see here also, there is a P wave here, there is a P wave here. There is no followed by QRS complex here. There is a QRS complex here without following a P wave. So this is a dissociated beat rhythm. Here also the same. This is a P wave. This is a P wave. This is R. Somewhere R is coming, somewhere P is coming. There's no fixed pattern. Like in Mobitz type 1, we have PR prolonged, and Mobitz type 2, we have PR fixed. Third degree heart block. So let's go to hyperkalemia now. How many? This is the last. Hyperkalemia is the last. So in hyperkalemia, we should know some things which are very important here. Tall peaked T wave. This is the tall peaked T wave. Then what happens? There can also be a loss of P wave. Again, tall peaked T wave. Almost the T wave has come to the length of, come to the height of QRS complex here. Widened QRX with tall T wave. So as the potassium level increases in the blood, the severity of changes also increases. This is very, very important. Let's go through it. Now, first, there was a P wave here. There's a clear P wave here, followed by tall T wave. Then what happened? There is a loss of P wave and the T wave went more taller. Almost it is like a QRS complex. Next, the widened QRS with tall T wave. So step by step, we have to remember. So the potassium is between 5.5 to 6.5. First thing we see is tall peak T waves. As it becomes 6.5 to 7.5, there will be loss of P waves. And then as it becomes 7 to 8, there will be widening of QRS. Then 8 to 10, there will be sine wave, ventricular arrhythmia, and asystole. So we should know these changes. This can come in exam for the question. We can see obvious tall T waves in this slide. This, you see, the T wave is so tall here. And let's search, is there a P wave or no? There looks to be. The P waves are not clear and the T waves are very tall. But there is no widened QRS here. So probably this patient can have potassium between loss of P waves and tall T waves 6.5 to 7.5. This is how you suspect through the ECG. Okay. Again, check here what is there. For me, the P wave is not very clear here. And also the T waves are not very tall. I don't know what it is exactly. That's it. We are done. I think today we will end here. We have only two things remaining. So atrial flutter, it's a, you know that it's a narrow QRS complex. So what we know, we'll go fast. Narrow QRS complex can develop in newborn with normal heart also, can occur in a diseased heart with valvular lesions, cardiomyopathy, pulmonary embolism with cardiac surgery. Patient with atrial flutter is increased risk of thromboembolism, so anticoagulation given before cardioversion. The same thing is for atrial fibrillation also. They are atrial flutter and fibrillation, they are at increased risk of thromboembolism. So anticoagulation should be given before cardioversion. Atrial rate 250 to 300 beats per minute, almost 250 to 300. Ventricular rate, if all beats are transmitted to ventricle, it can be more than 300. If half is transmitted, it will be more than 150. If 1/4, more than 75. Classically, this is very important. Sawtooth pattern of P wave on ECG. This one, sawtooth pattern of P wave on ECG. You see this? This is the sawtooth pattern of P wave on ECG. Treatment, DC cardioversion is the most important treatment of choice. And other things, the beta blockers, procainamide, amiodarone. So not very difficult slide. Mainly you will consider the sawtooth pattern of the P wave and the rate will be very high, 250 to 300. If all beats are transferred to the ventricle also beats 300, but if not all, it can be 150 to 75. So that means some beats can be missed. Here, there are here, not followed by QRS complex. That means this much of waves are not conducted to the ventricle. Okay. 1, 2, 3. Here, 1, 2, 3, 4. The atrial fibrillation, you can see the difference. Fibrillation is like just not like a sawtooth. It's like some moved line, but it is like a clear sawtooth. Very rapid atrial rate. He's telling 400 to 600, but just check. I don't know, will it go so high also? Very rapid atrial rate, 400 to 600 beats per minute. Fibrillating activity, that is characteristic irregular P wave, rapid oscillatory depolarization. QRS is irregular in height, duration, and rate. You see, QRS is irregular in height, duration, and rate. Treatment stable. If it is stable, calcium channel blockers, IV procainamide or amiodarone. If it is unstable, you will do the DST cardio version. Atrial fibrillation is the most common arrhythmia seen in adults but rare in children. The most common arrhythmia you see in children is the supraventricular tachycardia. So let's next, AF is characterized by extremely fast atrial rate. It can be up to 600 beats per minute, 350 to 600 beats per minute, and an irregular. It is an irregular rhythm. Ventricular response with narrow QRS complex. Okay, narrow QRS complex is very important. Irregular rhythm. So rapid erratic electrical discharge come from multiple atrial ectopic foci. So rapid erratic electrical discharge comes from multiple atrial ectopic foci. No organized atrial depolarization is detectable. So what happens? Atria beat can be 350 beats. Ventricular variable depending upon how many P waves are conducted. Rhythm is irregular. P wave, no true P waves can be seen. Chaotic atrial activity. This is the chaotic atrial activity. Here, this is the chaotic atrial activity. No clear P waves are seen. PR interval, there is nothing called proper PR interval. QRS will be normal, 0.06 to 0.10 seconds. Clinical tip, afibrillation is usually a chronic arrhythmia associated with underlying heart disease. Clinical tip, signs and symptoms depend on ventricular response rate. If the ventricular is also very fast, you will have a problems.